are ready to start. So we do have some participants online, and we are now sharing across to some of our social media pages as well. So that's super exciting because it just broadens the target audience a little bit, and most importantly, allows a lot of the patient community to be able to access this content without necessarily having to move around too much and attend conferences, get on planes and all of that. So firstly, a warm welcome.
Can you excuse me 2 minutes while I go and lock the front door of my office and nobody comes in?
Perfect. No worries, Dr. Williams. I'll just do the basic introductions in the meantime. So thanks so much to everybody for joining us this a very, very cold and chilly evening in September. A little bit of a strange time for us to all be freezing, and that is why I'm wearing this nice warm puffer jacket, because Johannesburg has been absolute blitz over the last day or two. Just a warm welcome to everyone. A couple of housekeeping rules for those of you who are new to webinars, which I don't think is many people after all this time that we've spent doing online interviews, etc. But just importantly to note that you are more than welcome to use the chat function for informal chats and to make comments. But if you have any direct questions for either of our panelists, to please use the Q&A function. That just assists us in being able to obviously track what gets asked and make sure that we answer everybody accordingly. So that little Q&A function is at the bottom. You should be able to see at the bottom of your screen. So that is it from a housekeeping perspective. So tonight we are going to be discussing IPF management, and that is obviously interstitial pulmonary fibrosis. And I'm really looking forward to having this discussion. From our experience at Rare Diseases South Africa, we have, of late come into contact with a vast amount of patients who have not only been recently identified, some of them were identified many years ago, but because of the change in treatment options, many of them have been almost kept out of the loop in terms of what's available for them. And we're going to be discussing two kind of elements around IPF. First things first, we're going to have the amazing Dr. Williams, who's going to be speaking to us just regards to obviously the medical management side of things. And for anybody who doesn't know, Dr. Williams is from Mill Park Hospital, and he's with the Center of Chest Diseases and Critical Care, and he's an absolute gem of a doctor to have. I know Dr. Williams probably won't remember, but he treated me for asthma when I was very, very young. And then we are also going to be joined today by a different type of specialist in the sense that, and it's so important, but we are joined by Xenia Buntting, who's a biokineticist, and just really going to be highlighting some of the, the other things that can be done in terms of appropriate management as well. So this is a relatively informal discussion. It doesn't have any direct things, and more to just really chat about some of the things, because that's often what patients need, is just some direct insight. So Dr. Williams, if I can start with you, I just wanted to ask you, from your perspective as a clinician, how do these patients generally present?
Well, before we even get into that, let me just say, first of all, thank you very much for inviting me. I'm really, really honored. Kelly, you do amazing work for rare diseases, and you're a heroine of mine. You really are, and you've done amazing stuff for us. So hats off to you, and keep it up, please. You're doing an amazing job.
We'll try.
I don't think people realize that clinicians like myself, when it comes to us accessing expensive diseases for our patients, we can do quite a lot. We can motivate the medical aids, we can give the science and all of that, and talk to our patients. But what really makes a difference with the funders and with the community in general is when patient advocacy groups get involved, because that really hits home with everybody. And my opinion is that a doctor versus the funder achieves something. A doctor with an advocacy group versus the funder achieves everything. And that's the way it should be. Patients need to take responsibility for their conditions, in that they need to sometimes take responsibility for accessing treatment of their diseases, which is a pity in this country, but it is not a reason to be negative. It's a reason to be very, very positive, because if you see what has been achieved by people like Kelly and others and other groups, it is a game changer. And we now have medication available for many rare diseases that when I started off in this clinic, even 20 years ago, weren't available. And, you know, us clinicians often didn't even ask to have these treatments available, because many people think, well, you know, the drugs are expensive. Who's going to pay for it? Who's going to approve for them? And there has always been a bit of an apathy amongst the medical community about accessing expensive treatments for rare diseases. And about 15 years ago, I started to examine my own position on this and say, no, this is not right. You know, this all grew out of a lung transplant program that we have here. And we found that funders were happy to pay for lung transplants because expensive GWIS operation that costs millions, most successful, which I'm still very passionate about. But a step or two before that, and you say, but how about treating the disease properly? And the funders say, well, the drugs are expensive and blah, blah, blah. But when you look at the expense of transplants versus the expense of a drug that is a non-transplant drug that works, you just can't compare them. And I became quite mad at the whole situation. And then my position evolved into one of, it's actually unethical to transplant patients unless you've treated them properly as they would be treated anywhere in the world. And if they fail that treatment and need transplantation, well, you've done your best. But if you're going to just see the patients and give them what we had available and then say, well, we can't do anything more, let's transplant them, that is completely wrong in my opinion. So, you know, my stance changed to one of, if a drug is available that is effective anywhere in the world, we have to have those drugs available to us. We have to have access to them and we have to get them for our patients. And then if those drugs don't work, as they often don't, then we can talk about transplantation. But it's not either or, it is both. You have to have both. So that's really where my passion for accessing drugs, like the ones we're talking about tonight, really grew out from. But the success we achieved was in terms of cooperation with organizations like rare diseases. This has really been a game changer, I think, and we've managed to, as a collective medical community with the support groups, change the face of what we're doing in respect of having effective treatment now available for many rare diseases. And we've saved many patients the need for transplantation. And that is the most important thing. Transplantation is something that you want to avoid at all costs. And if you can with medical treatment, you have to. So that's where people like Kelly have really come in and been at the forefront of the battle to get effective treatment available in this country for all drugs that are available anywhere overseas for rare diseases of any kind. I deal with lung disease, so that's what my interest is in. But there are many others that I know nothing about that Kelly and others know far more about and are involved with. Okay, so
thanks so much, Doc. I want to just say, you know, in line of what you just said, I think you strike such an important point in terms of, I think not only medical funders, but patients also having an understanding that in order to access these innovative products, there needs to be a good evidence base. And sometimes, as is the sad case with many of the rare conditions, there isn't always a commercial treatment available. Sometimes, you know, palliative care, supportive care is all that is available. And I find that patient cohort is so difficult because there's such a desperate need and they desperately want to live, that you're willing to try anything.
Yep.
But unfortunately, from an access perspective and a funding perspective, it's very, very difficult to motivate for, you know, for evidence, you know, trials, etc., or guesswork, if I can call it that. And it's just such a difficult thing. And that's why when drugs do become available and they go through the rigorous, you know, authorization process and regulatory process, and they've passed the necessary muster in terms of having the evidence base, it's so frustrating when we can't even still get access to them. And yeah, I think it's a very difficult place for patients sometimes to understand that conundrum that we find ourselves in.
It is, but it's a battle that is an ongoing one, and it mustn't be given up. You mustn't surrender to the forces that say it's not worth treating, or it's too expensive, or we can't do it, because in general it's not true. And when you see what can be done with a bit of pressure from our patients in collaboration with us and the support groups, one can do a lot. In cases where there isn't treatment available, I think that's also a very, very important point that you reached on, that you touched on, is that one way of accessing many of these drugs is in the form of clinical trials, because that is the feeder mechanism for all new drugs. And, I'm constantly amazed by how medicine has changed over the past 10 years even. 15 years ago, for example, another rare disease we're not talking about tonight, but I'll mention, is cystic fibrosis. 15 years ago, we could give antibiotics and supportive treatment and all of that, and we couldn't really change the prognosis that much. Now, 15 years later, there are very effective drugs available. So effective, in fact, that if you're a child born now with cystic fibrosis, if you have access to these drugs, chances are you will never have the complications of the illness. So it's almost as if you've had a cure at enormous cost. But if you're a parent with a child with cystic fibrosis, imagine the anguish you must feel if a drug is available in America and in England and in Europe, and you're told in this country, sorry, ma'am, but watch your child die. We'll help as where we can, but the expensive drugs that work aren't available to you. That's a terrible thing to say to a parent. And I don't think one should be accepting of that. And thankfully, in this country, our patients are very, very strong, and they band together. And the pressure that they collectively exert is something I'm in awe of, because it's one can literally move mountains with the combined effort of a committed parent or a committed patient. And what they really need is assistance from the medical community and from support groups that are well informed and are prepared to take on the battle and fight head on with the funders or whoever else. And sometimes it's not even the funders. Sometimes it is the drug companies themselves who are reluctant to bring drugs into this country that are expensive, because they are for-profit companies, and if they see the profit margins as being small, they might say, well, it's not a market we're interested in. We have to convey to them as well, we're not talking about markets here, we're talking about individual patients that are suffering. And one dare not say to a patient, sorry, we're not interested in your money because we won't get rich from it. We have to appeal to their moral responsibility and say, you have a moral right to make these drugs available to people that are in need of them, especially when they're very, very effective drugs.
100%.
So so I would appeal to patients, if you can't access the drugs, or if there aren't drugs available, whatever illness you're talking about, if there's a clinical trial in your area that's available, that is a very, very good way of accessing, at least getting your foot in the door of a pathway to treatment. And many of our patients have started off on drug trials, and years later, the drugs are found to be effective. Those patients have often had a 5, maybe 10-year head start on the drugs because they've been part of a clinical trial. And we've had many patients like that who've benefited greatly from clinical trials, just by having access to effective drugs, which nobody pays for, because trial drugs are free. The patients don't pay for them, and the companies that are studying them are compelled to provide them for free while they're being studied. Yeah. Then, of course, when the drug trial comes to an end, if the drug trial is effective, the drug is effective, our South African authorities are quite good about saying to the drug companies, sorry, you can't now morally say to the patient, I can now cough up and pay for it. You've taken part in the trial, you've helped to advance the science and prove the drug works, you've been part of the development of the science behind the drug, you will get that drug from that company for as long as possible. So yeah, that's a good reason, I think, to encourage participation in clinical trials, because it helps to advance science, and science is what we're all about at the end of the day. Because, as you say, Kelly, one has to have evidence and the stronger the evidence you have for the efficacy of a drug, the more ammunition you've got to make the funders pay for it. And if it's a very effective drug for an illness that is very bad, people on very thin ground saying, sorry, we can't pay for it, because that's why you're on a medical aid. And that's why you live, hopefully, a developed society that is going to help you access these very expensive treatments.
100%.
So,
I wanted to just reiterate on the Rare Diseases South Africa website, for anyone listening who might have a condition that they're not aware of, if there are any clinical trials out there, we do have, under the patient section, there is a little block on the right-hand side where you can actually put your condition in, and it'll actually spit out whatever clinical trials are happening across the globe. And sometimes it doesn't, they're not necessarily in South Africa, but in that case, it always helps to reach out to the authorities that are running those clinical trials in other parts of the world, because we are a gold mine in terms of being in Africa for treatment-naive patients. So,
absolutely.
Yeah, so just for any patients out there, if you're not sure if there is a clinical trial and there is no treatment available for you yet, there is always the option to go. And I would recommend that you regularly check in there, because things change all the time. So, Dr. Williams, tonight, when we're discussing interstitial pulmonary fibrosis, it's quite a complex condition from our experience, from a patient advocacy perspective. We're seeing quite a lot of elderly patients being diagnosed with this condition, and we see quite a delay in the diagnostic odyssey, largely, I think, because of the fact that the patients are aging. And as a result, you're not quite as active as you would normally be. I suppose as everybody gets a little bit older, you do become a little bit more out of breath. Doing extraneous activity does get a little bit tougher. And I think that a lot of the times patients put that down to the side effects of aging, so to speak. I mean, what would stand out from a clinical perspective, that if a patient is experiencing that continued breathlessness, kind of the fatigue, a little bit, sometimes the blue around the lips, and, if all of those signs that are common with the pulmonary conditions, like, what stands out for you in that sort of patient cohort that says, definitely get that checked out?
Well, you see, that's a very good point. And unfortunately, with most of the lung conditions that I deal with, be it pulmonary fibrosis or the other interstitial lung diseases, or pulmonary hypertension, which is my other major interest, the diagnosis is delayed because the symptoms are so common. And I know people are often, from a medical specialist point of view, we're critical of the general practitioners out there because they seem to miss these conditions. But I, in fact, have great sympathy for the general practitioner out there, because these illnesses don't present with specific standout features that would make the GP say, hang on, you've got pulmonary fibrosis, or you've got LAM, which is another interstitial lung disease, which we can talk about, or that. No, these patients go to their general practitioner often with symptoms that are so common that the general practitioner rightly thinks of all the common conditions first. Because, I mean, if your GP is diagnosing weird and wonderful conditions all the time, the first time he sees you, he's making a big mistake. Yeah. And so most of these conditions present with really common symptoms, such as shortness of breath, which is the commonest symptom, or a cough that doesn't go away and get better. Now, the commonest causes of coughing are not things like pulmonary fibrosis or cystic fibrosis or LAM or whatever. They are common conditions that the GP sees every single day: asthma, or a postnasal drip, or gastroesophageal reflux. These are the conditions that the GP will be seeing 10 times a day in 10 different patients presenting with these symptoms. And the average general practitioner may see a patient with interstitial lung disease maybe once in a year, maybe even less than that. And if it's one of the rare lung conditions that is an interstitial lung disease, such as LAM, which is lymphangiomyomatosis, which is a very rare interstitial lung disease, the average GP will never, ever see one in his life. The average specialist physician might see one case in his lifetime, And the average pulmonologist will probably see 3 or 4 in his lifetime as a pulmonologist. So these are really rare conditions, and they have generally the same common symptoms that all other common illnesses present with. So my advice always is that don't be hard on the general practitioner who says you've got asthma and then puts you into treatment and it doesn't work. If that is the case, my advice always is to go back to that same general practitioner and say, sorry, this is not working. My symptoms are no better. I don't think the treatment is working. I wonder if this isn't something else that I've got, not asthma. And, the average specialist also is going to take maybe 1 or 2 or even more consultations before the penny drops and they realize, but hang on, this is not something that is common. It's not something that I'm expecting to see, but I must look for it now because the symptoms aren't getting better. The patient's not getting better. Unfortunately, patients tend to doctor shop, which is such a dangerous thing to do because, it means that you're now going to a new medical practitioner and they're faced with the same decisions as that your first GP was faced with. And they are not much more likely to make a different diagnosis other than something common than the first guy was, or woman, sorry, I'm not being sexist here. So, you might have to go to your general practitioner 4 or 5 times or more and make them aware, sorry, buddy, this is not working. Whatever you're trying to treat me for, I know you're doing your very best and you're treating all the common conditions under the sun, but nothing is working. Can we think further beyond what you're treating? And my experience of the GPs in this country is that they're well informed and they're prepared to keep an open mind or to refer on to a specialist if they are faced with a patient who they are not managing to sort out. All doctors want to sort their patients out. So there's nothing more frustrating for a doctor at any level or any specialty to be faced with a patient that you're treating and nothing is working. So I think it's put the onus on the patient to be part of that medical decision-making process by persisting with a medical practitioner and helping them to become aware that what they're doing is not working. It's not because they are not good, not because they're not competent, but because they're treating the common things first. And that's the correct thing to do, in my opinion. And that is what all well-informed GPs are going to do in the first place. And in my experience, most of them, when they're faced with a patient that's not getting better, are prepared to have an open mind and say, hang on, what am I missing? What does need to be done? And then move on. So shortness of breath is the commonest. A cough is also a very, very, very common symptom. Patients with interstitial lung disease, like interstitial pulmonary fibrosis, the cough is a very early feature of the disease, and it's a very, very, very persistent, non-productive cough that just doesn't get better. And the patients cough and cough and cough and cough. And you can imagine having a very bad cough when you're short of breath and getting more short of breath is a very unpleasant situation to be in. And, when the antibiotics have failed and the cortisone has failed and all of that, then that is generally when the patient will then be referred on to a specialist to say, hang on, is there something else wrong here? These illnesses can be picked up relatively quickly if one does specialized investigations like a scan of the chest, for example. But once again, your average general practitioner isn't going to do a chest scan on all of his patients, because if he did, he would be shouted down and kicked out of town, because the medical aids, first of all, would not allow him to do that. His patients wouldn't want to pay for it, and people would think he'd gone slightly off the wall if he was doing that. So you also can't expect your first call medical caregivers to do the fancy investigations. And in fact, it's often best that they don't, because the specialized investigations are often of such a nature that there's not one investigation that needs to be done. There's a whole bunch of them. And having them all done by one person in one place is often the wisest way of doing it. It's certainly the cheapest way of doing it, the most effective way. So, if your primary practitioner is not doing all the specialized investigations, don't be harsh on them. That's the right thing to do. But that must lead to an escalation of your problem up the medical chain to a specialist who is going to take it seriously and going to take those investigations further. And in my experience, the guys in this country are aggressive and they're good with doing that.
100%. I think you know, the issue about patients monitoring their changes in their response to treatments is imperative, not only in the rare disease space, but, you know, patient education when it comes to, regardless of what treatment you've started, if someone's prescribed you something for headaches, for pain, for fever, whatever it might be, keep track of how you're feeling on that treatment. And also don't wait until your symptoms have got so severe again. You know, if you're not responding and it's, you know, 3 months down the line, we always, you know, push the issue of having a patient tracker and, you know, a symptom tracker and monitoring any changes and how you react to them. And this becomes such a pertinent point, particularly in the rare disease space where new products are becoming available and new research is being done. So if you start a treatment because it's the only treatment available at the time, and you experience severe side effects as a result of that treatment, you're not going to stop taking the treatment often because there isn't an alternative. But so you'll stick with what there is because it's the only choice you have. But then when it comes time that a new treatment does become available and you want to make the switch, and now you're having to engage with your medical scheme around making that shift, and often the new products are more expensive, you are having to rely back on proving the point that you have actually not been a non-responder on the existing treatment or haven't responded as well, or you are having a severe side effect profile. And you know, sometimes it's frustrating for us from an advocacy perspective when you've got to say to the patient, right, we almost have to start from scratch again. We're going to have to monitor you for 6 months, monitoring you aggressively to actually prove that track record. So a very, very important thing that I think patients, no one kind of prepares himself for being a life of a chronic illness patient. And it's such an important thing to kind of be aware, you know, be aware of from the outset, is that response to treatment and its importance. We've had a question from I can only presume is a patient on the Q&A that's asking specifically around a non-specific interstitial pneumonia with regards to fibrosis and how that has an impact. Are you able to give a little bit of information around that?
Yes, I certainly can. I think let me just step back a little bit and explain what this whole broad group of diseases is, because it is very, very complicated. And interstitial lung disease is a whole group of conditions. Let me just explain that the lung, I think everybody's probably got a basic understanding of what the lung looks like. But basically, when they talk of the lung as being a big sponge, it's like a sponge. That's a good description of what the lung really is like. There are two sacs on either side of your chest that have got millions and millions of tiny little air sacs in them, all of which are in direct communication with the air outside that you breathe. That occurs through the airways from your mouth down your trachea to your bronchi downwards. These airways branch many, many, many times and get very, very small until they become microscopic, and they conduct the air from the outside of the body to the very furthest part of your lung. Interesting to think that all that is separating you from the outside air, even in the deepest part of your lung, is one layer of cells thick. That's the only barrier that's standing between you and the outside environment, which is really pretty awesome if you think that that the area of that environment is, you know, they say the size of about a tennis court. If you were to squash the lung flat to spread it out, it could be about the size of a tennis court. So your body is, the air that you are breathing in is exposed to a surface area the size of a tennis court. That is where the air goes to. Now, that whole surface is also supplied by blood vessels from your lungs that also get smaller and smaller down to capillaries, where single cells of blood go through in single file through the capillaries past the airway. So really the lungs are, from that point of view, quite simple. It's a barrier between the air and the blood supply. That barrier, like I said, is one cell layer thick, and the red blood cells pass by in single file, picking up oxygen from the air. Now, the lung has to be supported by certain types of tissue that hold it in place, like a skeleton almost, and give the lung its shape and keep everything in place. Now, that tissue is comprised of various types of protein, such as collagen, which I'm sure everybody's familiar with. Collagen is a protein that's a structural protein that keeps the structure of things in place, and other different types of protein. These support the structure of the lung. And it is also a very, very, very delicate structure that has to delicately support the membrane that separates you from the air outside and supports the blood vessels and holds it in place. But it also holds many immune cells that help to protect you from anything that you might inhale that's harmful to you, harmful substances, germs, viruses, bacteria, fungi. All of these things are a threat to your lungs. And the immune response of the lung is a very, very powerful one. And this is housed in the supporting structure of the lung. There's lymph tissue in that, there are lymphatic cells, and the supporting structure is very important. But when it undergoes any sort of injury that is harmful to the lung, I think the most obvious example to give is something like an infection like COVID. COVID, when it attacks the lungs, it causes that part of the lung, it causes all parts of the lung to become inflamed, but it has a predilection for the part of the lung that's part of the support structure. And when the lung is harmed by an injury, it needs to heal. And lungs heal in many different ways. They can, sometimes from viruses and bacteria, they can heal completely. And a diseased lung that has, for example, an infection like pneumonia in it, can be restored to completely normal by the body's immune system. But not always. Sometimes there are injuries to the lung that cause the lung to heal by scarring. And that scarring is the same kind of scarring that you would get from a surgical cut or from a cut that you might have on your arm, your hand. Some people scar quite heavily, and you might have noticed that some people, if they have a surgical cut, when their wound develops, they get a very, very prominent wound, and it is firm and hard and very strong and very healthy in that situation. But if that scarring process is very excessive, it's going to cause scarring throughout the very fine part of the lung that is the support structure. And that scarring is what we call fibrosis. And fibrosis is generally a normal, natural healing process. But in many of these interstitial lung diseases, that scarring has become out of control. Now, with the interstitial lung diseases, there's a whole group of these diseases which are very complicated to understand from any point of view, but may be a response to an injury of some kind, may be a response to an infection of some kind. It may be a response to a genetic illness. It might be a response to an acquired abnormality of the genetic pathway of the cells. Or in many cases, there's just simply no known cause. Doesn't mean we've got no idea what causes these illnesses, but we just don't understand fully what the cause is. And the interstitial pulmonary fibrosis that I think most people are familiar with in this forum is an example of that. We don't know what causes it, but we know that the response to whatever provokes this illness is scarring of the lung that is so excessive, it becomes injurious to the body. It's harmful. And it causes the natural structure of the lung to become distorted. And when the lung is distorted, it really means that the parts of the lung that are involved with the gas exchange are scarred. So the blood doesn't go to the right place, the air doesn't go to the right place. And it means that much of the work that you do breathing air in and out is spent moving air past lung that is not really effective, not working properly. And What also happens is the scarring affects the natural elasticity of the lung. The lungs are very, very, very elastic organ in real life, in health. And if you take a lung, a normal healthy lung, you could literally, with one hand, compress it so that it fits inside the palm of your fist. It is so compressible. But then by the same token, it is easily inflatable. If you expand it like a balloon, it takes very little air pressure to blow up a normal lung fully, like a balloon. That's why breathing is so effortless for most people in health, because the lung expands and collapses like a balloon with very, very, very little effort. And the natural elastic properties of the lung are so remarkable that one can move liters in a minute without any effort, your whole life, without even thinking about it. And there's no work involved that you are aware of, because your body naturally overcomes this, and your metabolic processes supply the energy for that, and you're not short of breath. When you've, example, exercised very, very heavily, you will know that when you're battling to breathe and catch your breath, you're having to work very, very, very hard to breathe. And that's because you have to breathe hard and fast and move a huge amount of air in and out to be sufficient to supply your needs. Now, you can imagine what happens if your lung is damaged or scarred and becomes stiff and is not as elastic as it was. If your lung is very inelastic and becomes stiff, it means that the effort that you need to move air in and out of the unhealthy parts and the healthy parts of the lung is very, very much more than the normal person. And that is what causes you to become short of breath. Shortness of breath really is the awareness of the need to breathe. I mean, most of us aren't aware of breathing at all, and that's because you're not short of breath. But if you exercise, you will become short of breath. And all that really means is that you're aware that you're breathing heavily. And after exercising, of course, you expect that to be the case. And, you know, it's very normal. It's a pleasant sensation if you can be short of breath after exercise and then catch your breath and gradually get better and it wears off. You're left with the satisfying feeling of having exercised hard or whatever, and then recovering completely. If your lungs are diseased and you're having to breathe hard all the time because your body's demanding oxygen just to be able to survive, that causes shortness of breath. And it is a very, very distressing symptom to have. And if it doesn't go away or get better, it's difficult. And of course, if you do any effort and you walk up a flight of stairs, something like that, it's as if you'd run a marathon, and then you really are short of breath and you have to breathe very, very much harder for a long period of time. And then you're not going to be able to get to the point where you're comfortable again, because even when you are not exercising, you're still short of breath. So that is the distressing symptom of being short of breath that patients with pulmonary fibrosis have. And it is a very, very distressing symptom. And it can't be relieved just by oxygen. You can't take it away just by oxygen, because if you need oxygen, you'll be short of breath. But even if you don't need oxygen, but you need to remove carbon dioxide, you're going to still experience that same shortness of breath, because you have to breathe to get rid of carbon dioxide. And even if you don't need to get rid of carbon dioxide, your lung just being stiff and abnormal is going to cause a sensation of air hunger and being short of breath much of the time. And it's not a very pleasant symptom to have at all.
Yeah, I mean, geez, just listening to what you were saying about it, the lungs being that tiny single-celled membrane, I mean, kind of puts into perspective why lung infections are such a thing, because there's such a limited barrier. I mean, the inside of your lungs are so exposed to the outside of environment. You don't think about it because they're inside your body and you don't see them. But I mean, when you think about that pathway, I mean, it's actually quite remarkable. And, you know, you're referring to the sensation of the stiffness in the lung. I can imagine it, you know, similarly to if you have been cut and have had stitches, that kind of thick scarring that forms where that wound is healed together. And that's generally often inflexible. So I can just imagine that is what it feels like, you know, from a lung perspective. So it makes a lot more sense, I think, for patients, you know, and I think that we often don't get an opportunity to hear from such a wealth of knowledge, just the practicality of how these conditions materialize and how they impact. And, you know, very often in the moment when you're in front of someone and you've just been diagnosed, or you only generally go to the doctor when you're sick. So there's often an acute issue that needs to be addressed at the time. So you never really get these opportunities to just actually have like an informal discussion to better understand the condition. So it certainly has helped me. I wanted to move, it's Xenia, I just wanted to ask you, in terms of what Doc was just saying about, you know, the physical exertion and that stiffness. From a biokineticist perspective, what are the elements that you focus on in terms of, you know, rehabilitation? And I know you've done a lot of work with patients with long COVID. And, you know, and I can imagine just anybody who worked with lungs during the COVID, you guys have had a rough time. Yeah, it's been a bit brutal, but, you know, what are the elements that are necessary to focus on when it comes to rehabilitating the lungs, and what are simple things that patients could do at home in terms of, you know, trying to regain some flexibility in the lung?
Okay, so with regards to rehabilitation, the rehabilitation program has to be specialized. It's not just one size fits all. As Doc mentioned, interstitial lung disease consists of a range of different conditions. So people are on different types of medication. They've got different limitations. They have their own unique needs. So that means each program should be specialized based on their goals, based on their treatment that they're receiving, based on their medical condition. So before anybody engages in any of these exercises, they should definitely speak to their doctor or their local biokineticist in order to receive an assessment first before beginning. But a couple of stuff that we do include in our rehabilitation program would be to do some aerobic exercise. So these are activities such as walking, cycling, swimming, rowing. This helps to improve the cardiovascular fitness, enhance the efficiency of oxygen utilization, and reduce that symptom of breathlessness. So while it does increase the chances of breathlessness as they get fitter, as they remain on their treatment, Doc also mentioned also using a little bit of oxygen, then it should be easier for them to do a little bit of aerobic fitness. Other components include strength training. So what we find with interstitial lung disease is that a lot of people suffer with muscle weakness. You know, the saying of you don't use it, you lose it. But because these individuals don't have impaired exercise tolerance, so they do in general suffer, like Doc said, they could be walking upstairs. They don't recover quickly, so they're not drawn towards exercise to begin with. But then in turn, it does result in a little bit of muscle weakness. So that would include doing a lot of body weight exercises. They can use some resistance, such as the resistance bands or some free weights. I do also find that a lot of people now suffer with bad posture. You know, we sitting in front of a desk or computer, you tend to slouch, right? Now with slouching, let me just do that. Slouching, it does cause there to be a little bit of issues with breathing, right? So I would also work on increasing the muscles in the back. So just to open up that individual so they are able to take in breath, because we don't want to worsen the condition. Breathing is already a struggle. We've got to make it as easy as possible for that individual to take in breath. So strengthening up the back, opening up the shoulders a little bit more. You can also do some, I call them chest openers or book openers, where it's just like holding a band in one hand and like opening up your chest, just like that, and closing as well. Working on the bigger muscle groups, like your thigh muscles. So just doing stuff which is functional, like everybody has to get up out of the chair, get up out of the bed somehow. So you do need to work those muscles. They do put a lot more strain on the lung and cardiovascular system. So it is going to be tough, but you got to progress slowly with those exercises. One thing is to ensure that you've got proper form when doing these exercises so that you don't cause further injury. You need to do a little bit of flexibility and range of motion. Okay, flexibility, especially when it comes to the thoracic spine. So that is like your middle back region. So doing like little cat cows. So I'm going to try and show you as much as I can in this little video. So just
loving the interactiveness.
Yeah. So just in a seated position, and you can do this on all fours as well. So hands on the knees, you're going to round. So bring your chin towards your chest, rounding that back, dropping that head, and then you're going to go to the alternate. So pumping that chest out, looking up towards the ceiling, just to get a little bit of mobility in that back, in that thoracic spine, so that you don't limit, because that's in fact where the lungs are sitting. They are covered, as Doc said, by the ribs. So we need as much mobility there and not stiffness. So flexibility exercises just to prevent muscle stiffness, to reduce discomfort, and to improve mobility. Then also, and it's not a common one, but doing balance and coordination exercises. So because the individuals don't end up being physically active because of these symptoms, they tend to have a little bit of muscle weakness. With that muscle weakness, they tend to lose a little bit of their stability. So weak muscles, the joints aren't protected. They lose that stability. So even just standing on one leg, open eyes, closing the eyes, adding a little bit of movement. So if I stand on one leg, I grab a little, even a little water bottle, yeah, and I just pass that from one hand to the other. So that's dynamic. The movement challenges the balance, putting one foot in front of the other, like you're walking on a little tandem, a little rope, okay, just to challenge that balance, to improve their stability and reduce their risk of falling because of that muscle weakness. And then most important, I believe, is the breathing exercises. So there are multiple different techniques to help improve breathing because these individuals suffer with the breathlessness. We need to try and improve their lung capacity. So I've got a couple of techniques we're going to test out as well today. So I've got pursed lip breathing. Right, so that just means I'm going to be breathing like that. So if you can just imagine having a little straw in your mouth, and basically what you're going to do is you're going to sit or you can stand in a very relaxed position. Make sure you've got the good posture, right, so that we open up those lungs nicely. And then what I want you to do is gently inhale through your nose for about 2 counts. 1, 2, and then you're going to exhale through those pursed lips for about 4 counts. If you can go longer, go longer. So this inevitably just helps slow down your breathing rate, reduces the breathlessness, and improves the efficiency of oxygen exchange. Right, then we've got diaphragmatic breathing or abdominal breathing. Right, so generally people do this lying down. You want to be in your most relaxed position, but I'm going to show you seated. So what I want you to do is you're going to place one hand on your chest and the other hand on your tummy, right? And the only reason I ask you to do this is so that you can see if you're breathing, pardon, with your chest or if you're breathing with your tummy, right? So technically the rest will be lying down, feet flat, hands on, one on tummy, one on chest. You're going to inhale slowly through your nose. And then I want you to allow your abdomen to rise as you do that. So everybody's so used to breathing through your chest. Don't cause the chest to move. You're going to fill up your tummy, right? Fill your lungs up with air. Then you're going to exhale slowly through your mouth using the pursed lip, letting your abdomen fall. Okay. Right. And then that technique definitely helps strengthen the diaphragm muscles, enhances oxygenation, and reduces the reliance on shallow breathing. So the only reason, so with the normal chest breathing, it doesn't allow your lungs to expand as much as with the diaphragmatic or the abdominal breathing. All right. Then we've got segmental breathing, right? So this just directs airflow to specific areas in the lung. So how you're going to do it, you sit or you stand comfortably, one hand on your upper chest, the other hand just like by the end of your ribs, right? So where your last rib is, right? Lower rib cage. Then you're going to inhale slowly and deeply through your nose. Focus on expanding your lower rib cage first. So very similar to the allowing your abdomen to fill up. And then from there, you're going to allow your upper chest to expand. So now we're involving the chest as well to fill up. Right. This technique does promote balanced lung expansion and improves ventilation in areas that are affected in interstitial lung disease. I'm sure many of you guys have also seen, there's this tool that many use. So it's basically a little pipe, and then you've got the little different color balls, and as you blow through it, each ball will lift up. A lot of rehab specialists also use that. I know you can use it for inspiration and expiration as well, and it's a very good measure to see if you are improving, because one goes up, then that means you are breathing, but you can improve, you know. So that tool is also used quite often. And then my last breathing technique is called breath stacking. Okay, so this technique helps maximize the lung capacity and improve lung function. So exactly what it says in the word, you're going to stack your breath. So what you're going to do is very shallow. You're going to inhale with a very shallow breath, and you're not going to exhale. So you're going to inhale shallow, pause, inhale again, pause, inhale again, pause until your lungs feel comfortably full. Once you do that, you can exhale very slowly and very controlled, right? There are some also fun ways to do this. I mean, when you ask people to do the breathing, the session gets a little bit boring for some. So sometimes you'll ask them to do it with a little balloon. I must say the balloon can be a bit tough to do in the beginning. Breathing is already a struggle for these individuals. So you've got to take it slow and work your way up to the balloon. Another progression, which is a little bit easier than the balloon, is I take a little straw, I inhale, and I've got a little bowl with water in, and I exhale into the bowl of water. The water does provide a little bit of resistance, but it's not as tough as the balloon. So you can start doing this without anything, and then add little stuff to challenge you and keep it exciting. But the main thing is to, even with all the other exercises, the strength and the flexibility, you've got to try and practice the breathing techniques throughout. So definitely suggest doing the breathing at first. Once you've got the swing of that, then you can do the breathing with a little bit of a sit to stand. And if you can only manage to do 2 reps of that exercise, that's fine. We've got to work with what we've got at first and build on it slowly. You can't compare yourself to everybody else. Everybody's journey is different. Everybody's condition is different. Everybody's on a different treatment. So don't be too hard on yourself, but take it slowly and progress slowly but surely. But as with all things, we need to be consistent with the exercise in order to see and reap the benefits of these things, and frequent practices of these exercises will definitely help individuals manage their breathlessness and enhance their overall lung function. So unfortunately, rehabilitation through exercise doesn't cure interstitial lung diseases, but it definitely helps manage their condition, improve their functional capacity and their overall quality of life, because our goal is to keep it, to make sure the client, the patient, is taken care of as best as possible.
Very
Also,
interesting.
yeah.
And I mean, I was doing them as well. And for someone, I think with
Yes.
a relatively relatively healthy lung capacity now,
Yeah.
like breathing out through the pursed lips actually is, I think I'm going to start using it when I'm wanting to kill someone, because it really does. It's just in controlling that exhale. Like I've
Yes.
never tried it before, and it is actually really, really effective. And also just like that breath stacking, you start to
Yeah.
realize, I mean, I think I'm a lazy breather, and I'm
Exactly.
relatively healthy, but I'm sitting here like, oh my gosh, I never actually breathe that deep. So
Yeah.
I think, as someone has asked a question on the chat around access in the state facilities, and many of the state facility patients don't have access to the nice biologic drugs because they're not available in the state facilities. So
Yeah.
as it is, the supportive care is really what the focus is for those patients, but they don't get to go into, for regular physio, they might only go to clinics once every 3 months or once every 6 months.
Yeah.
So to have practical things that they can do at home that come relatively at a relatively, inexpensive,
Yeah.
and that kind of gives you a baseline to work from. One of the
Yes.
such an important thing for rare disease patients is to remain as healthy as possible, so that when the
Yeah.
next bunch of, when the next group of treatments come available, that you
They're
are in a
able.
position that you qualify for treatments, that you meet the entry criteria. So critically important is to, try not lose more and try and maintain what you have at the time that you're
Yeah.
diagnosed. So thanks so much for giving us some simple interventions that patients are able to do at home. And I'm pretty
Yeah.
sure that we'll probably have a lot of patients that, maybe this is something we can do some pictures with or something as we go, just to try improve
So,
the
yeah.
access that patients have to these expertise. A question that has come up on the Facebook page is with regards to diet as well.
Yeah.
I'm not sure, Dr. Williams, if you have any specific recommendations for patients that are battling with the pulmonary fibrosis. I know some say a low sodium diet. Obviously, trying to minimize your fat intake is important. Carrying extra weight places unnecessary strain on bodily systems, but the downside is that these patients generally aren't in a position to do huge amounts of activity. So I think maintaining a healthy weight comes down to the dietary restriction a lot of the time. Do you have any recommendations with regards to that?
Yes, I think that is extremely important. I mean, our patient's body weight is a hugely important area for us. And as you said, if you're overweight, the ability to lose weight by exercising is removed from you if you're very short of breath. So it's very difficult to lose weight if you're overweight. By the same token, many of our patients with all forms of lung disease tend to be underweight because the amount of energy that they expend just by breathing to survive is huge. So many of our patients have difficulty in taking in enough calories to meet their energy demands and to maintain their body weight or to increase their body weight. So my recommendation on that is really quite straightforward. To seek the help of a professional. We all work in multidisciplinary teams in the big hospitals, and an essential member of the team are the dietitians who help our patients to maintain a normal body mass index or the normal body weight, at the same time maintaining their strength. It's extremely important to focus on the rehabilitation, as Xenia has said. We are very, very supportive of the fact that rehabilitation is a major component of treatment. In fact, it's as important as a drug. So we can't give our patients drugs and then say, well, try and take this medication and go home and hope for the best. You've got to say to your patients that, the drugs are what we're doing to try and help you, but focusing on a rehabilitation program is just as important as one of the drugs. So that must be part of the approach. Very, very important to do that as well.
Yeah, 100%. I think it's one of, there's this notion, I suppose, from patients that if it's a lung condition, we only focus on the pulmonologist and that's it. I think we often forget that every organ in the body is reliant on the other organs being equally as healthy and as fit and as being able to do their job well. And this multidisciplinary approach becomes such an impactful, and we can see it as clear as day with the patients that we help navigate. The patients that are treated in a multidisciplinary center just have much better outcomes than patients that have a single tract focus. And it's incredibly sad because the public hospitals do such a good job when it comes to actually handling the issue around multidisciplinary care. And those clinics are so effective, and that's why having centers of excellence are so important, because as part of the treatment plan, you are bringing in the variety of expertise. Whereas in the private sector, very often you'll have your cardiologist at one hospital, your pulmonologist is at another. They kind of don't chat very often. They don't see each other on a regular basis. They're not passing each other in the passageway in the morning or at the coffee shop. So, we have this fragmented care in the private sector, and it's one of my big dreams, is the hopes that we can get the centers of excellence off the ground, and we can start looking at innovative ways to bring the expertise together. And even discussions such as this really help, reduce those barriers and break down the silos that we often have, and just so incredibly important for patients. I see we do have a patient with their hand raised, but I think we're limited in terms of functionality. So if I can ask that patient to pop their question just in the Q&A, because of the fact that I don't think we have the ability to open and unmute. It would just make it a little bit easier, and we can guarantee that we answer your question there. We did have one more question that came through on Facebook. There's actually been quite a few comments that have come through on Facebook, but the one important thing that came up, firstly, that everyone's saying thank you so much for the information. It's been so imperative. But someone has asked, is interstitial opacities in the lower lungs possibly more from COVID? And could permanent phlegm in the back of the throat, nose, and cough be connected as a result? So I think obviously when discussing this, when discussing anything pulmonary related, inadvertently we're going to land up with long COVID questions because of the need. So Doc, what's your view there?
Well, long COVID, in many instances, look, not everybody understands the same thing by the term long COVID. But if you're talking about long COVID as it affects the lungs, it generally does look like it is one of the interstitial lung diseases, and it generally has the same symptoms and many of the same features when you look at the patient on a scan and that sort of thing. And yeah, scarring of the lungs by fibrosis is certainly part of long COVID, and it can look very much like the other interstitial lung diseases. The one positive side with COVID is that my experience is that patients generally tend to get better from COVID. It might take a very long time, but I've certainly got a number of patients who were very ill and very impaired for over a year or two, but have continued to gradually get better from their COVID. So if patients are suffering from COVID-related lung disease, not to lose heart, but to continue with rehabilitation, for example, because the natural course seems to be that in the vast majority of patients, they will get better. We have had the odd patient that has required consideration for lung transplantation. That is very sad, but that's the exception to the rule by a very, very long way. Patients generally tend to get better. When we're talking about those technical terms that radiologists use, they're very complicated terms that we use to communicate with each other medically, but we don't even always use the same terms and language. So it's very difficult for patients to look at their X-ray reports and their scan reports and know exactly what's being referred to, because even within the medical community, these terms don't always mean exactly the same to every one of us. So as far as I'm concerned, when I'm seeing a patient, I want to see the scan. I want to see the pictures myself and get my own impression rather than reading a report, because the report often doesn't convey to me what the pictures do. So I always want to see the pictures myself. That's just a technical point, really. So
I think an important point for any patient seeking out support, go with your, take the time, wait for the disc. If you
absolutely.
And if you're going to another hospital in particular, so if your scan's been done at one and you're visiting a doctor in another, to take the physical disc with you, because they often aren't able to access the system.
If you can get that across to 10 patients that see me in the next year, I'll be so grateful, because
I'll make it my mission.
The biggest bugbear of my life, and patients need to be told this, that your X-rays and your scans are your property. They don't belong to the hospital or to the radiologist. They are yours. And you should demand, they'll do it for you freely, but they often don't do it because most patients, well, many patients aren't interested and don't take their x-rays with them, and they don't take their scans with them. So my hospital has, in fact, stopped making CDs for their patients because it was just such a waste of money. But that is your property and your information, and it is absolutely invaluable. So please ask for your scan on a CD as well when you go and have it done. Or if you don't have that done, get a link where you can download the scan, or where I can download the scan if I happen to see you. Because, and most X-ray departments in the country will freely do that. So I'm able to access scans from across the country just by asking them to give me a link, and I download it. But if you can, to take a CD with you or take the pictures with you, it's far more important than reading a report by somebody.
You know, it was a family member of mine, a close family member, was in hospital recently for a scan. And I said to her, you need to get the, you know, don't only get the report, you actually need to get the physical disc. And her response to me was, will they give it to me? And
Yeah.
I was just like, yes, it's yours. So I think that there's this notion that, you know, it's like behind a paywall type thing. It's like behind this firewall. It's we often on a day-to-day basis, patients are identified much later down their diagnostic journey with a rare condition, and we're having to track back, you know, baseline assessments from 10 years ago. So difficult to do. It's like your patient records are 100% your responsibility, and I can't stress it enough. When the riots were happening down in Durban, we had patients who didn't have copies of their scripts. And now the pharmacy that you would regularly go to was no longer there. The pharmacy had been raided. The computer systems had been ripped out the walls. There was nothing left. And now we were desperately trying to access patients' scripts. You know, these things, it's such a simple thing. When you're at your doctor, take a snap, keep a folder on your phone, you know, with a copy. Like that in itself is already a great start. When you're seeing the cardiologist and he wants to know, what have they prescribed, and you're not sure on what the dosage is, that's like a really like a quick intervention to be able to keep all that stuff together. Doesn't always have to be sexy, it just has to be functional. So if taking a picture is what we're going to, if that's the easiest option for you, then I'd 100% recommend that you do it.
Absolutely. Couldn't agree more.
There was also another question with regards to whether or not there is a pulmonary fibrosis support group. And yes, there is. Again, it's not sexy. We don't have Rare Diseases South Africa. I think we have 187 disease-specific support groups that we manage. It's not always, we don't always have very formalized structures. It doesn't always result in us all being able to physically meet while we do try and make it possible. But we do find a mechanism to connect you with other patients, other people, your village, you know, people who are going through the same thing, who understand the condition, and to be able to connect you in with the necessary support and expertise. So those structures are in place, and we encourage all patients to reach out to our patient coordinator, the lovely Nomsa, who will connect you with other patients or connect you in with those support groups and those systems, taking into account that the rare disease space, sometimes we only have 1 or 2 patients in the whole country that have a particular condition. But to find just one other person who gets your language, who speaks it, who gets it, who understands, like that peer-to-peer support is absolutely imperative in terms of giving patients the necessary resources to cope. And we've discussed, you know, the need for rehabilitation support, the need for physio, exercise, diet, obviously good medical expertise, mental health support. If your brain isn't able to get into it, and you are battling with, you know, dealing with the overwhelm of living with chronic illness, dealing with depression, anxiety, and all the things that often come into the mix when dealing with these very, very complex conditions, like it's half the battle lost. So if we can connect you with those necessary support systems, we obviously do have the free counseling services available as well. Those are made available online to all of our patients who need them, completely free of charge. If you're needing to reach out for those services, please do not hesitate to ask. Honestly, it's just such an imperative element to dealing with these conditions on a day-to-day basis. So, I mean, I can't believe it. We're already at 8:15. Absolutely crazy. It felt like we started this 5 minutes ago because it's been so interesting. But I just wanted to ask Xenia, Dr. Williams, I'll start with Xenia, ladies first, Doc. Do you have any closing thoughts, or, you know, just in a nutshell, if you had to give patients one last piece of advice in terms of what to deal with when dealing with these interstitial lung diseases, what would it be?
So what I'd like to just reiterate of what Dr. Williams said, that a multidisciplinary approach is necessary. Like, you're not just dealing with a lung, right? That's a whole individual who needs nutritional support, psychological support, who needs medication, who needs exercise. So you need to look at the individual as a whole and not just focus on just one part of it. And you find that once you deal with everything, the individual starts to become better. For example, most of these individuals will suffer with a little bit of depression, sometimes anxiety. I can imagine you are struggling with breathlessness. It's only going to increase with your anxiety. So you need to have your support groups. You need to go for your counseling. You need to try and be as active as you can, because you don't use it, eventually you'll lose it. You need to stick to your medication. And like Doc also said, you need to be able to inform whatever specialist or professional that you're working with. Hey, this is working, this is not working, because either we need to progress you, we need to regress you, we need to change the treatment plan. So don't be shy to say, this is not working, I don't like this is how my body is reacting to it, and it's not good. I take longer to recover. It takes me a week or 2 days or so and so. So things can change to suit you, because it's not a one size fits all. What I can do with this patient with interstitial lung disease, I can't do with the other. Okay, so we have to find a specific and unique way of dealing with you, because we're all special at the end of the day.
100%. Thank you so much for that. Dr. Williams, any closing thoughts?
Yes, I think that those are very wise comments there. We're a small country when it comes to medical expertise. We don't have the wealth of number of doctors and specialists in this country that they do overseas, but we do have access to most things. And we can generally, in this country, I think we're known for our resourcefulness amongst the patient community as well as our medical community. And, I think many people in this country have got a practical attitude of, let's solve the problem and do what we can. And you should be able to access help, even if it is difficult, even if it takes more effort than it would elsewhere in the world. The correct help for most people, for most conditions, is available in this country. And if it means asking people, sometimes for a favor even, if it's your health, your life on line, ask people for help. Ask people to recommend people, help you, or ask your doctor to help you. If you haven't got a medical aid and you need help, ask. You'll be surprised what people will do if you just ask. So don't assume up front that that there's no assistance or no help available. There actually is. And you'd be surprised how many of our patient community are part of that help as well. So often our patients, when they are finished with their medication, if they've got excess stock, they give it away. They give it to us, and they help their fellow patients. So we need to build our community spirit more. It's out there already, and let's just strengthen it as well.
Yeah, 100%. I think while we've been giving these closing comments, I think there's been two things that have cropped up on the Q&A. One being around patients feeling, that they're not able to access support, and they're not able to visit their clinicians because of the fact that they are required to make upfront payment. So just from an advocacy perspective, there's two elements to that. One, like Dr. Williams has just said, ask. Many doctors are actually willing, and are happy to take a payment plan, etc., etc. Two, we must move away from this notion that the medical aids have given us this understanding that things aren't necessarily covered. Very, very often, we should have your follow-up appointments, your initial appointments, etc., should be covered under a basket. They should form part of your basket of care so that we can ensure that those patients are well managed all year round. And I mean, it is absolutely pointless implementing patients on expensive, innovative, high cost products or complicated, disease management, and they're not following them up because of the fact that there's no funds left. So we, for 100%, between Nomsa and myself, are happy to take this issue up with any medical schemes to make sure that patients have access. So if you are needing to see your pulmonologist and the pulmonologist has recommended that you see him every 6 months and your medical aid says to you that they're only going to pay for you to see him once a year, please, we ask you to send those cases to us because we'll take that up. If it is in your interest to be followed up more regularly from a cost-effective saving perspective, the medical schemes will land up saving longer at the end of the day by making sure that patients get treated and followed up more regularly. There's no point keeping a patient, and this is something that we see often in the epilepsy side, keeping a patient on a neurological patient on a treatment for 6 months when they're having more seizures after implementation of that treatment. You'd rather change their treatment to something more effective sooner than wait the 6 months until your next follow-up. And another thing, just because, if you are not responding well to your treatment or you're not having the intended benefits, an important question to ask your clinician: what should I anticipate seeing as a result of implementing this treatment? If you are not seeing what they've suggested, the reason that they've put you on that treatment to begin with, go back sooner rather than waiting for your 6-month follow-up. Honestly, you're saving yourself and possibly your health in the long run by doing that. And then the second thing that came up was what can be done in terms of obviously creating awareness around these issues, particularly in an emergency room setting. So that's why these conversations are so critical, and that's why we bank these conversations on on our resources, etc., so that a patient that's diagnosed tomorrow will be able to access a discussion that's had today, 1. But 2, we have developed our emergency room cards. So it's like a little bank card, really. But we are able to adapt them to the patient's condition. You can mention what medication you're on, etc. And anything that your doctor feels is important to express in a time where that you might not be able to speak for yourself. And those are available on our website that you can order them. And it just provides you with an opportunity if you're in a car accident and somebody needs to understand something about your condition. It gives us the opportunity to write a lot more than what you can necessarily fit on something like a medical alert bracelet, where you're limited to 140 characters. So at least this way, you can express the really, really important things. So if you are on a particular drug that needs to be noted in an emergency setting, what your condition is, where people can, where they can find access resources on that condition, just gives you an opportunity to be, and it's something easy to give to family members as well. Very often our family members don't know how to advocate for us in those situations. This is an opportunity for you to be able to speak through the mechanism of providing someone with a card and asking them to read what's on it. So those are 2 very simple interventions that we have introduced to be able to assist patients in that regard. So I would suggest any patients listening, if you haven't ordered those cards, I'd suggest that you do so. Honestly, they've made such a world of difference. And in the pediatric patients as well. When you're sending patients to school and your reliance on teachers, etc., being the voice for you, it makes their job so much easier to have something like that to rely on. So those are the closing thoughts from me. I want to thank both Dr. Williams and Xenia for such an engaging conversation. I really enjoyed doing a little bit of my exercises here this evening. I'm going to keep practicing. Dr. Williams, thanks once again for your wealth of knowledge and just being so available to your patients. We really, really appreciate having doctors like you in our midst. And we're looking forward to having more engagement, but most importantly, thanks to the patients and the members of the public who have joined in, who've listened to this conversation on social media, who have asked the questions that they've asked. It honestly makes such a difference. And never think that a question's a dumb question. You might have asked something today that will save a patient tomorrow. So when in doubt, ask out loud. So 100%. Thank you so very, very much. And we look forward to having more discussions like this. And we hope that you guys go on to have a good evening further. We appreciate you very, very much.
Thank you so much, Kelly. Thank you very much.
Perfect. Have a great evening, everyone.